We are now going to discuss the Frailty-Freed phenotype. The Frailty phenotype is predictive over 3 years of incident of falls, worsening mobility or ADL disability, hospitalization, or death. According to Freed, frailty differs from disability and the following features. Frailty is different than undernutrition, dependence, prolonged bed rest, pressure ulcers, gait disorders, generalized muscle weakness, extreme old age, weight loss, anorexia, fear of falling, dementia, hip fractures, delirium, confusion, going outdoors infrequently, and polypharmacy. In geriatric medicine, a syndrome refers to a multifactorial health condition that occurs with an accumulation of deficits and impairments in multiple systems, resulting in increased vulnerability and adverse outcomes. Frailty has been considered synonymous with disability, comorbidity, and other characteristics, but thanks to Freed's work, it is now recognized as having a biologic basis and considered distinct clinical syndrome. Prior to her work, a standardized definition had not been established. In Freed's study, comorbidity was defined as 2 or more diseases, for example, MIs, CHF, PVD, arthritis, cancer, diabetes, hypertension, COPD, and there are really over 2,600 conditions. Disability was defined as self-reported difficulty with 1 or more ADLs. To be classified as frail, individuals had to have 3 or more of the following: unintentional weight loss, self-reported exhaustion, weakness, slowed walking speed, or low physical activity. In her study, 370 were classified as frail adults. 60% of frail have 2 or more diseases, and 27% have difficulty with 1 or more ADLs. But what is important is that the majority of those with comorbidities are not frail, nor are they disabled. Also, 26% of frail elders are neither disabled nor have comorbidities. Frailty is not synonymous with either comorbidity or disability. Comorbidity is an etiological risk factor for frailty, and disability is an outcome of frailty. There is an intermediate stage identifying those at high risk for frailty. Why is frailty important? It manifests as decreased ability to tolerate stressful events, and it's associated with adverse outcomes that we stated earlier, including falls, delirium, long-term care placement, and increased mortality. Risk factors for frailty include poor surgical outcomes, prolonged hospitalizations, deconditioning, and faster functional decline. Frailty impacts reserve and function across multiple physiological systems, and it's associated with higher healthcare utilization and costs. Identifying frail elders. We definitely need to look at patient history. Is there an unintentional weight loss, which is typically considered 10 pounds or 5% in the past year? Is there self-reported exhaustion, feeling that everything is an effort or that it's hard to get going on 3 or more days per week? Is there low physical activity? Then there's the strength assessment, looking at weakness, specifically grip strength, if it's in its lowest 20% for that age group and gender. Depending on BMI, cutoffs for grip strength were less than 29 to 32 for men and less than 17 to 21 for women. And also gait speed, slowed walking speed, 15 feet in 6 seconds or more. 3 or more of the criteria indicate frailty. 1 or 2 criteria indicate risk for frailty. Characteristics of frailty. This we have already stated, but just to review. Weakness, especially in grip strength. Slowness, as in gait speed. Low activity, so decreased physical activity or they're sedentary. Poor endurance, so reporting exhaustion, or shrinking, as in weight loss. The criteria are if an individual is considered robust, they have 0 criteria. If they are considered pre-frail, they have 1 to 2 of those characteristics we just spoke about. And frail is 3 or more of those characteristics. Let's talk about the pre-frail. This is the intermediate group that presents with 1 or 2 of the criteria. Intermediate risk of the same poor outcomes that someone who's considered frail might face. And an increased risk of becoming frail, twice the risk of becoming frail as compared to non-frail individuals. This pre-frail group is usually the most receptive to what we call pre-rehab. This group meets 1 or 2 criteria, but not the third to classify it as frail, and are very responsive to exercise-based interventions. Here's a review of the spectrum of frailty. All the way on the left, you can see robust, and they are considered resilient and not frail. Pre-frail, you're considered vulnerable. They may decompensate with external stressors, poor or very slow recovery, and often precipitates onset of frailty. Frail is considered an increased adverse to outcomes, increased dependence, and a poor recovery. And pre-death is considered end stage. The individual is often dependent and has an increased disability. This is a chart you can review on your own just to give you a further understanding of the different categories an individual might fall into. You do not need to memorize these numbers. This is just for your own reference. Frailty and mortality. Older people with frailty have the highest risk of mortality, followed by older people in the pre-frail phase. Older men with frailty have a higher risk of mortality than frail older women. The frailty cycle links the anorexia of aging, chronic malnutrition and sarcopenia, loss of strength and slowness, reduction in physical activity, and decreased energy expenditure cycle. Decreased energy expenditure leads to further anorexia, and the cycle begins again, making the older person more and more susceptible to poor outcomes that may eventually lead to death. What other factors influence frailty? Although there is tremendous variability in the functional levels of older adults, there is a general limiting factor that transcends this population due to multi-system age-related changes that they experience. That is the physiological reserve. Therefore, challenging patients to achieve the highest level of functioning before a subsequent event takes them over the edge is so important and is part of our role as occupational therapists. Psychological factors that may influence frailty are depression, anxiety, cognitive function. Sociodemographic factors include income and living environment. Lifestyle factors include diet, smoking, and alcohol consumption. And then finally, thinking about the risk for falls that older adults are at. Please review this pathway on this slide to further understand how an older adult may become frail. Here we've listed different frailty assessments. There's the gait speed, 5-time sit to stand test, short physical performance battery, hand grip, easy care 2-step older person screening, and the clinical frailty scale, as well as the frailty indicator questionnaire. Here I've just demonstrated the gait speed assessment that you can practice on your own. This is the simple frail questionnaire screening tool. These are good assessments to keep in your toolbox, along with those assessments that you've already made what we call cheat sheets for, right? These are good to have just on hand if you, are facing someone who might be considered frail.